Hello, this is Fred Stodolak from Panacea Healthcare Solutions, and this is part two from our hospital zero-based pricing demonstration. In part one, we looked at the comparative health data system to establish customized peer groups for use in hospital zero-based pricing. So let's go into the hospital zero-based pricing system where we'll find the actual peer groups that were established in the comparative health data system. And if you recall, by checking off this box, there's no need to upload that information. It will actually be found in the zero-based pricing module. So let's go there now. The hospital zero-based pricing system is one of many modules within the CDMauditor.com suite. But today we're going to focus on the hospital zero-based pricing module. Similar to the comparative health data system, this module was also reviewed by the HFMA distinguished panel and by our clients, and we did receive the peer review designation as you see here on the bottom of the screen. Let's log into the system. The system is web-based. It uses encryption technology. And what we'll do is we'll go down here and we're going to use a XYZ demo hospital. So even though we used Hennepin in our previous example, this is not Hennepin's data, but at least you have an idea of how to create those benchmarks and how we could take that information, and we'll show you here in part two how to take that information and utilize it to do some what-if scenarios in gross and net revenue models. So the first step is to familiarize you with the main menu. On the left you see upload. This is where you would upload your charge master, your usage data, your charge payer percentages, and if you are having difficulty loading this, our technical support team is always there to help you, or for no additional cost, we'll actually do the upload of the files for you if it's too challenging. This is also where we would manage any of our payer fee schedules. We do load up into the system any commercial managed care fee schedules. Automatically, you'll find the Medicare and APC fee schedules for your organization in the system. This is where you would manage payer caps in the system. So in addition to charge payer percentages, if you have payer caps, we manage that within the system here so we could calculate the impact of our model on payer caps. We also have a unique feature in the system where you could actually take historical usage data and you could apply either hospital-wide by department and patient type, or even at the department, payer, and patient type level. You could actually apply percentage increases or decreases to the historical data if you're aware that a specific payer or a specific plan or a specific department is going to experience a change in volume. You could actually factor that in here, use it not only for your budgeting process, but you could factor it into the model that we do. So we also have a costing feature. If you want to start to incorporate costing into your pricing or into your profitability reporting, and you don't have a cost accounting system, Panacea offers an optional unit cost estimation system. Typically, our financial consultants will come on site for 8 days. Within a couple hours, we will be able to train your department heads, department managers on how to point and click to make decisions, and within a few hours, each department will be costed out. And as I said, we spent about 8 days on site, and we then spent about 6 weeks of back office reconciling with the trial balance and with the personnel records supplied by you. And the end result after 2 months is a fully costed charge master where we have direct costs, fully allocated cost, and if requested, we could even develop variable cost. If you're a health system, you could switch between organizations within the health system, and of course, you could switch back to the comparative hospital data system directly from within this system. So let's get started on the pricing. The nice thing about zero-based pricing, it's easy to use. It's a simple 10-step method where we choose the pricing method, we select the files, we can mark up the cost, assign any price increase or decrease for inflation. We could then choose the peer group that we want to utilize, choose the fee schedules we want to utilize, and what kind of floor or markup floor we want on those fee schedules. We could run the reports for all departments or selected departments, for all payers or selected payers. We even have the option to exclude certain line items based on just the simple dollar value. And of course, we have the ability to do any overrides to any of these steps, where for a specific department or specific service code or HCPCS code or revenue code, we want to apply a different rule. We can do that using the overrides. And of course, then we get our results on the summary page. So it's that simple. We answer these 10 steps, these 10 questions, and the result is a nice model. And then we could continue to refine the model and do what if scenarios. It's not uncommon to run 30 or 40 models before actually coming up with the model that everybody's happy with and that we implement. Usually the first step is to do what we call a baseline across the board model. If absent the use of zero-based pricing or absent a defensible rational pricing strategy, the hospital typically would do a 4, 5, or 6% across the board increase. And if the goal is to achieve the net revenue increase that would have been achieved if a 5% across the board increase were implemented, but instead rational pricing methodologies, zero-based pricing methodology was utilized, then we would run a 5% across the board model to establish a baseline. To do that, we go right into this price increase step, put 5% in the high contribution area and 5% in the low. The 5% represents the 50% of the charge master based on volume that has the highest charge payer factor, and the low is the bottom 50 percentile based on charge payer contribution factors. And for an across the board, we're going to put 5 and 5 in each because that represents 100% of the charge master. The reason Panacea breaks this out is some clients want to focus mainly on decreasing charges with a minimal impact on net revenue. To do that, you might actually put 0 here. You might put a minus 10 here. That would actually result in a 5% overall decrease in gross revenue, but it would actually have probably a 2.5% impact on net revenue. So that's why Panacea breaks this out this way. But for our purposes today, we're not going to utilize that feature, and instead, we're just going to use it to get our baseline number. So it's 5 and 5. We'll hit save. We'll hit run. And now we can see how much net revenue the client would have gotten with a 5% increase. And you see the gross revenue goes up almost $72 million with about a $2.8 million increase in net revenue. So we're going to try to do a model letting the benchmarks do most of the work, but keeping an eye towards the net revenue not going below 2.8 so that this client will get the best of both worlds. It will achieve the $2.8 million net revenue, hopefully, or more, but also have more defensible pricing. In part one, if you recall, you saw many, many prices, probably 30% or more of the client's prices were more than 140, 150, 180% of the market average. So our goal in this model is to create a corridor. We're going to create a corridor of 100 and 115. So our goal is that any prices above 115% of the market average will come down to 115%. Any of those below 100 will come up to the market average. But we're also going to take into account the unit cost for the procedure and the fee schedule floors that we talked about earlier. Again, keeping an eye towards the final result being at least 2.8 million. So what we did is we went through each of these steps and we go to this near final model. And let's just go through each step and I'll show you what we've done here. Since this client did have unit cost, we're going to use a hybrid approach. We could have done a purely market-based model, cost-based, or hybrid. Some clients that are interested in cost-based but don't have the cost available yet we might recommend doing market-based in year one, and during year one, do the cost study so that in year two, we could then move to the hybrid. In this case, the client had a cost accounting system already and gave us the unit cost, so we're going to choose the hybrid. This is where we select our files, and you can see it's the unit cost information right here, the usage data, which is at the plan code, service code, patient type level. We've got it says payer collection percent, but it's really the payer charge payer percent. There's actually, if you go right here to view file data, you could take a quick look at what we load up into the system. It's pretty much the heart of the system from a net revenue standpoint. And if you notice here, I'm going to skip down to find a different payer. Here's a good payer. This payer A30, if you notice, it says 0 for inpatient. That means they probably are being reimbursed a per diem or a DRG rate, because what this is saying is that the inpatient charge payer collection percent is 0 for this payer. However, on the private outpatient side, they're getting 50% reimbursement. On the same day surgery side, they're getting no charge pay reimbursement, which means they're probably getting a bundled rate. And on the ER side, emergency room side, they're getting 67% of charges. So we enter that information not just by plan code level, but by every department. There might be some private outpatient departments that are a fee schedule, and for those with fee schedules, you might actually see a 0 here. So we do get to that level of detail. It's at the plan code level, patient type level, and we even have the ability for certain service codes where they might be getting invoice cost as an exception to actually modify specific service codes as well. So that's the some of the inputs into the system. We'll go back to the model. So we chose the method, we selected the files, and we can go and see we actually marked up the cost by 644%. The hospital gave us direct cost, not fully allocated cost. So we had to mark it up for overhead, for shortfalls from Medicare, shortfalls from Medicaid. We had to mark it up for bad debts and for a profit margin. So in effect, we did this through trial and error. We said, how much do we have to mark this up to achieve net revenue neutrality? And we backed into the 644, and in effect, using that approach, the markup is that high because it does have to account for those items I just listed. I'm going to uncheck this peer group optimization, and we'll get back to that later. Let's go to the next step. We're going to leave the 5% increase in there because it's not actually going to affect any line items where the price is already above the peer group. So for example, if all those prices that the hospital is above 115%, they're going to be limited to the 115%, which means this 5% inflation increase is not going to apply. The main reason we're going to put this in here is about 25-30% of hospitals charge master probably won't have a good benchmark, maybe cost, but may not have any other benchmarks. And we might want to just apply 5% for inflation purposes. We put a limit on decreases of 35% and a limit on increases. Most clients, can't absorb all in 1 year the full effect of going down to the peer group average or up to the peer group average. So it's regulated over a multi-year period by doing this. By checking off maintain consistent prices for HCPCS, if the hospital has the same HCPCS code being used multiple times in the charge master with different prices, then the prices will go up or down based on the benchmarks, but they'll maintain different prices based on the current relative value relationship. We have a new feature where the client could choose to use a Panacea RVU for those HCPCS codes, and that's coming out in September. This is where we chose the peer group, the corridor of 100%. Prices will go up to 100%. Prices will come down to 115%. And we applied a 2-year inflation factor. In most cases, this would be a 1-year inflation factor. Panacea will be receiving in September the 2015 data for hospitals, and it already has the 2016 data for physician services. This is where we establish a floor of 0.7 for bundled procedures of the Medicare APC rate, 2.5 of the unbundled APC rates, 2.5 of the Medicare fee schedule, and for the commercial fee schedules, which are already 4, 5, and 6 times higher in some cases than the Medicare rate, we use 1.1 or 1.2 in some cases. In this model, we're going to use 1.1. The reason the commercial fee schedules we only use 1.1 is because they are already so much higher than the Medicare, and the reason they're so much higher is because it's based on customary charges, whereas the Medicare rates, many clients forget it's based on cost. And many hospitals that have been setting prices in the charge master based on a multiple of the Medicare rate, they probably would be better off using our comparative health data system lookup tool rather than using a floor of 2.5, because it often results in a lesser of charge and fee schedule problem. Let's go to the next step. We could run for all departments or selected departments. This client had some departments with zero revenue in it, so I decided to select certain departments that had revenue. We're going to run for all payers. We could run for selected payers and for selected patient types. This is a good feature for giving payers any detailed reports they may request related to your charge increase if needed. But for modeling purposes, we're going to run it with all payers and with all patient types. We go to the next page. This is where if we had a trigger of $1 or 25 cents, some clients have certain items in their charge master with a certain dollar amount for stat procedures or for a trigger for an explode, and that's where we would be able to just blanketly exclude those line items based on the dollar amount in the charge master. So for this client, we did run the comparative health data reports, and we did run a previous model, and from that model we learned a few things. And what we learned is that for these departments here, operating room, ambulatory surgery, we decided we just wanted to implement a 5% increase. So we're basically going to override those parameters in the model because we found that the cost was taking the price up by 20% in the operating room. There is no benchmarks, HCPCS benchmarks in the operating room, and there was relatively no charge payer mix, so it didn't make any sense to raise the prices 20% if there was no net revenue benefit. It would simply just make us look worse on consumer reports. So for these departments, we've decided to just limit it to an inflation increase, and we could have even kept it flat. These departments here, respiratory therapy, dialysis, these are areas that have a very, very low charge payer mix, and it was essentially the same thing. And the charge payer mix was so low compared to these other areas that we decided to keep it flat. So essentially, those are the overrides you see there. We did go into the rev code override feature to refine the model a little more. And this is where we decided to reduce our room rates by 20%. So for the 110, the 120 rev codes and some of the others that are room rate related, based on the comparative health data report, we saw the room rates were very, very high for this client, and we decided to lower it by 20%. We saw on the department summary that they had a very low charge payer mix because they get paid per diems and DRG rates. So we're comfortable doing this. And we also are increasing by 10% pharmacy. We noticed on the comparative health data charge to cost markup reports, as well as the HCPCS reports for the J codes, we found that the drug prices were low, so we actually put a 10% increase in the model using the override feature. And then finally, the supplies were high, so we're taking them down by 20%, and we could even go more next year. And the implants, however, the devices and implants were low, so we're taking those up by 10%. Finally, we do have the ability in the system to do overrides at the service code level, and that's something we usually don't do until we start vetting the actual audit trail report, which is the Excel worksheet. But just to show you how easy it is to use, I'm just typing MRI, and I could find all the MRI procedures. So if I wanted to do an override to those MRI procedures, which means I could select, for example, any one of these, and I could turn off, for example, the use of the peer group corridor. Or if I created a special imaging peer group, I could have turned, I could leave this on, this corridor, and I could actually pull this menu down, and I would find my imaging peer group or oncology or cardiology, and I would choose that instead. So this is where I could fine tune the model for specific departments or to address specific situations. But in this case, I'm just trying to show you the feature, and I'm not going to actually make any service code overrides. And with that, let's hit save and run. We'll see the impact. It's that simple. And within seconds, you could see we found that the gross revenue is actually going up only 4.4%, 63 million, versus this 70 million plus with the 5% across the board baseline model. We're actually about 2.6 million versus 2.8 million, but the difference is we have reduced drastically those prices that were way above the peer group. And we have done that by raising some of those that were below. So we have some prices based on cost, some based on fee schedules. Most of these prices are getting closer to that market corridor of 100 to 115%, unless they were limited by the 35% increase-decrease cap. So we do have one more thing we can do. We can use Panacea's proprietary optimization formula. We utilize this only at the very end. It's always ideal to run a model with a good result and not have to use this feature or not use it until the end, just to preserve the overall integrity. The nice thing about this feature is that unlike traditional optimization, which results in irrational pricing, the peer group optimization method, what it does is out of the thousands and thousands of line items in the charge master, you could enter just 15 or 20 line items and it'll find the best 15 to increase and the best 15 to decrease. However, it will not increase any price beyond what we've defined as being a reasonable price. So for example, if we have prices due to the 35% increase cap that are sitting at 90% of the market, it may now go up to 100 or 115%. If you have prices that are sitting at 110% under this method, it may go up to 115%. You may have prices that are sitting at the 115% that have a very low charge payer mix, and we might actually bring those down to 100% of the market average. So we have prices going up and down, but it's only your top 15 going each way. So you might have 15, you might have 30, 15 each way. And let's see if that approach, which does still keep prices rational, let's see if that results in any additional net revenue. Now, the nice thing about it, it's going to take prices up and down and keep the gross revenue the same. Wow, that's great. We actually picked up another $1 million. So you can see here the gross revenue stayed the same. There's your $63 million increase in gross. It's less than the 5% across the board slightly that we would have otherwise implemented this year. And we actually are picking up $3.5 million of net revenue. So we're actually getting a 6.2% increase in net revenue, even though our gross revenue is going up 4.4%. But again, the best part is that we've begun to reduce those very high charges, those charges that were very high above the peer group. We know that have, well, most of those have come down by at least 35%. We have a 35% cap on decreases. So what we can do here is we would click this Excel worksheet and we could actually start looking at the reports in detail. So to save time, I've done that, and let's just take a quick look. There's a few reports here. You have a department summary. This is just like what we saw on screen, or what we can see on screen. And what I wanted to show you is here it is. Here's the same 4.5% we saw on screen. And looks like there's a slight difference with this report because I ran it earlier. But essentially, you've got a 2.5% increase in net revenue had we done a 4.5% increase across the board. But we actually picked up what we call a bonus under the zero-based pricing of $973,000. That is just simply the effect of prices going up and down based on the benchmarks, plus utilizing Panacea's peer group optimization method. We are going to lose $74,000 because we're actually over the cap, and we actually increased revenue by about $18,000 because, unbeknownst to the client, they had charges that were below the fee schedule. So we're actually going to get some additional fee schedule reimbursement to the tune of $18,000. So when you add these together, you subtract this and you add the 18, you actually get net reimbursement increase of $3.4 million compared to $2.5 million had we done a 4.5% across the board. If we did a 5% across the board, if you recall, this number was 2.8, and that's still almost $650,000 more than what we would have gotten with it across the board, but we have more rational pricing. And we actually have the documentation for how these prices were developed in the audit trail report right here. And we have other reports, patient type summary, where you can see the breakdown of the 4.4% increase by patient type. You could see the net revenue broken down by patient type. We have a breakdown by payer of the impact. And you could see here's the payer cap, 74,000. This same payer tab not only shows you the gross and net revenue changes at the plan code level and at the patient type level, but this is where you would actually see the quantification of your payer cap issues. So for Coventry, we're at 7.7% charge increase with this new charge structure. The cap is 6%. We're 1.7% above the cap. So we have the potential to have $22,000 taken back. And if we do that for other payers, here's Cigna, it adds up to about 74,000. But that's 74,000 is a drop in the bucket compared to some of the other benefits we're seeing here in the model. And it is good to try to get as close to the cap as possible. So being slightly over and being at risk for 74,000 is not really a problem. We have a dashboard report for presentation purposes. We have the lesser of charge report here. This is the report that shows the additional 18,000 we're picking up. We're still leaving another 200,000 on the table, and normally we would spend more time and vet this, meet with the client, and see if these are false positives or whether there's actually more increases that the client feels comfortable doing. It could be that we're not picking up the full 200,000 due to the 35% cap, and the client may decide to go all the way up to the fee schedule, which means there would be an additional 200,000 there. We do have a price upload report that would go to the IT department to implement the new charges, and there's a summary of all the parameters, that we loaded up into the system, the 2.5 floor, the 1.1 floor on the fee schedule, the markup factor of 645%, the 35% increase decrease cap, the across the board inflation factor. So everything we put in the model is summarized on one page. And then finally, the last thing I wanted to show is we did a filter on the audit trail report of the top two increases in net revenue and top two decreases. Let's just walk through to make sure we're comfortable. If we're comfortable with the big increases and decreases, then we're probably comfortable with the model overall. So this is an emergency room procedure. This was currently being charged at $13.39. The cost marked up is $11.53. Let's see what the peer group. The peer group is charging almost $1,700. So in this case, we have room to go up to the market average to $16.96, and in the model, the final price is $16.96. It is a 26% increase, but if you recall, we are going to be taking some prices up and some prices down. And as long as they're going up only to the market average, that's pretty much the 50th percentile, give or take 5 or 10%, which means that for every 10 hospitals, there's probably 4 or 5 that are going to be even higher than this. And so I'm comfortable with this. We see $130,000 net revenue impact, and that new price is at the market average. If we look at the second one, we're picking up $160,000, and if we go over, let's see what's happening here. This procedure, it's a cardiac procedure, has a $14,000 price, $13,984. The cost is $7,000, but the other hospitals are actually charging $20,000. Let's see what our final price is. The final price, if we go all the way out here, is actually $18,878. So we didn't go fully up to the market average, and the reason is because it hit the 35% cap. So it might be that next year we'll actually go fully up to the market, but this year we're limiting it to the 35%. Now, the nice thing about this is right within the worksheet, the client could decide to do an override, which I did here of $20,000, and we would pick up an additional $36,000. This $20,000 user override, which you make directly on the worksheet, would automatically update this price upload report. So you could still make overrides in the worksheet and give this upload report to the IT people to load up into your charge master. Let's take a look at some of the decreases. The decrease is, these are two cardiology procedures again. Current price is $67.50, both of these. Current cost marked up for both of these is roughly $2,000. So let's take a look at what the market's doing. So the market is $4,800. We're charging $6,700. So, and our cost is below the peer group average. So what's nice about this is we're going to be decreasing the price from $67.50 to the market average of $48, which is actually right between the cost and the current price. So this is a good place to be for two reasons. It's lower, substantially lower than our current charge, which brings us closer to our cost. And it's nice because we're not above the market average. We're very close to the 50th percentile by doing that. And so I do feel comfortable that even though we're losing net revenue here, it is justifiable. In other words, we are losing $178,000 of net revenue for that procedure and $164, but we are gaining it on these two. So the net effect of these pluses and minuses on the entire model is, in fact, the $3.4 million that we were discussing earlier. So thank you for your time. The next part 3 is to discuss, for those hospitals that have stop loss provisions or lesser of charge and bundled rate provisions, for those hospitals that might be at risk of implementing this new charge master, at risk of losing stop loss reimbursement, or if they're curious to see for the first time, or with their current charge master or with the revised charge master, to see whether they have a lesser of charge problem on bundled rates. In part 3, we'll show some reports that we produce by taking the new prices, laying those prices over 12 months worth of claims data, itemized bill claims data, and simulating the impact on those provisions. We also, in part 3, will discuss a charge, cost, profitability, and cash discount profile for top procedures, medical and surgical procedures. So thank you for your time today. I hope this was informative.